It is my pleasure to welcome Dr. Biscaglia, an interventional cardiologist at the Ferrara University Hospital. Congratulations again on your late-breaking trial at TCT, the AQVA-II trial, that was simultaneously published at JACC Interventions. I want to jump right into it. Dr. Biscaglia, can you go over the hypothesis and the methodology of the AQVA-II trial?
Yeah, thank you, Abdullah. It's a pleasure to be here. So yes, basically, we have some data showing that physiology-guided PCI could be meaningful, but the target FFR trial that actually tried to use physiology on top of angiography-guided PCI gave conflicting results. And we basically tried at first with the AQUA-I trial to understand whether angiography-derived FFR was better than angiography per se in guiding PCI. But actually, we enrolled, I would say, simple lesions, and the primary endpoint of the study was post-PCI QFR. So I would say surrogate of FFR. So this is background because we decided to design another trial to understand whether physiology is superior to angiography in cheap lesions, so complex patients.
Perfect. Can you kind of go over the results and before the results, the two aims of this trial?
Yeah, because actually, as you said, Abdullah, we had two aims. The first one, I would say the most important one, was again to demonstrate the superiority of physiology-guided PCI over conventional angiography-guided PCI in achieving a post-PCI outcome expressed as post-PCI FFR. So all the patients in the study receive a blinded post-PCI FFR at the end of the procedure with a blinded pullback to understand the results in terms of physiology. And this was the first aim. The second aim was to test, at least preliminarily, the non-inferiority of angiography-derived FFR compared to invasive FFR that was measured by microcatheter-derived FFR to guide and optimize PCI.
Perfect. And what did you guys find out?
Yeah, we randomized around 300 patients in a 2-to-1 fashion to physiology or angiography. And the patients randomized to physiology were randomized to either angiography-derived FFR or microcatheter-derived FFR. And as for the two aims of the study, what we found out is that actually physiology is superior to angiography in achieving an optimal post-PCI FFR, and optimal post-PCI FFR was expressed as the number of patients achieving at least 0.86 as post-PCI FFR value. And we found out that this would happen in 54% of patients randomized to angiography, conventional angiography-based PCI, compared to 77% of patients randomized to physiology-guided PCI. So actually, we found a 23% absolute difference that was highly significant. And we found the same for the FFR value. So actually, all the physiological values were in the same direction. As for the second aim, what we found out is that actually there was no significant difference between the two different physiologic tools utilized in the study. So basically that angiography-derived FFR resulted non-inferior to microcatheter-based FFR in terms of number of patients achieving the optimal post-PCI physiology, and in terms, obviously, of the non-inferiority margin that was set across the post-PCI FFR value. So these are the two main results of the study. In terms of the secondary endpoint, so the procedural ones, so basically, is the procedure longer? Do you use more contrast media and so on? What we found out is that actually you don't use more contrast or more or a longer procedure with physiology overall. And this is because actually differently from the target FFR, we started with the physiology pullback at the beginning of the procedure, not at the end of it, not once you already have done what you thought was good, but to guide your procedure. And so it was not different. Even if we have a look at the two different physiological tools, they were different because you were more prone to perform multiple physiological assessment with the microcatheter if compared to angiography-derived FFR, and this translated in a longer procedure with the microcatheter if compared to angiography-derived FFR and more contrast. So I would say that overall physiology was not longer and painful if compared to angiography-guided PCI, but there were some kind of different grades across the tools utilized.
Yeah. Congratulations again. And it's really important. And, you know, we show the superiority of the physiology, and also you showed that it doesn't make people's lives harder, which both are very important aspects. What do you think? Where do we go from here? What's your future directions, and should we expect an AQVA-III trial?
Yeah, I hope so. And the idea is that obviously what we found out is that we were able to optimize from the physiological standpoint, and we know that post-PCI physiology is related to outcome, but we have for sure to demonstrate that this is actually impactful for the prognosis of the patient. So I would say that the next step is for sure a trial aimed at the clinical endpoint and not at the post-PCI FFR.
Perfect. Congratulations again, Dr. Biscaglia. This is truly impressive, and thank you so much.
Thank you, Abdullah. Thank you very
Thank you.
much.
Take care.